Thank you, Jane. And also, I'd like to thank Melissa French and the NAS for the opportunity to participate in this workshop. This is not my usual venue, but it's good to learn things, even if you have to sit for most of the day, which we as adults, I think, find difficult. So let me give you some background. As you heard, I was responsible as dean of a school for the education of dental students. And I needed to think, and this became particularly clear towards the end of the time that I was dean, about what is the future of the profession and what will our graduates be doing going forward. This sort of informs you about some of the research I've done. And in addition, I think it's important, and it was mentioned just a few minutes ago, that this workshop focuses on health literacy. And we're broadly defining health literacy to include not just patients being aware of their own health status and how to react to that, but what do providers know about what other providers are doing, and how can we increase that aspect of literacy? It was a little disappointing up until Dr. Snyder's presentation to see that this bidirectional arrow of integration of primary care and oral care was very heavily weighted, or oral care moving into primary care as opposed to the other side of it. And I'll speak to some of that. Let me just say, for those of you who are not familiar with the literature, there is really an expanding body of literature and growing professional support for the expansion of the scope of dental practice to include primary health care. And I think that's an important statement that we all need to be aware of. The population in developed countries is aging. The increase in chronic diseases are familiar to all of you. Tooth retention is increasing. As a result, dental providers will see a much greater number of older patients with complex medical histories who are used to good oral health care and will demand oral health care. So we really see the dental office as an unrealized healthcare opportunity. Now, there are hundreds of thousands of oral health care providers, and as you also heard, and I think as you're also familiar with, the time that is allotted to a patient, especially in the preventive phase, is much greater than it is in medical care. So I think this is an opportunity that is not to be missed. For the past 25 years, my primary research has been in the area of oral health and diabetes mellitus. That seems to be a recurring theme because it's not the only association, but it's the one in which the amount of data, the volume of data, the breadth of the data is greatest. You heard about the numbers. 10% of adults have diabetes mellitus. 25% of these are undiagnosed. This is by the latest data that came out of the CDC. And then, of course, there's the emerging problem of prediabetes, which may affect 30 or 40% of the older adult population. There is a very wide range of oral health care changes or oral health changes that develop in patients with diabetes mellitus, not just periodontal disease, but you get a reduction in salivary flow, burning mouth syndrome, the swelling of the parotids, and I can go on. There are probably 7 or 8 different manifestations. But in terms of the research agenda, let me just cite a few studies. A recent review examined the identification of diabetes mellitus or dysglycemia in the dental office, and it reported on approximately 12 studies. But let me just highlight 3 of those studies. And these were all came out of the United States. One was out of Buffalo, one was out of Michigan, and one was out of Columbia, out of New York, that contained at least 1,000 patients that were screened for dysglycemia. And obviously the entry criteria were not patients who had previously diagnosed dysglycemia. 30 to 40% of those individuals were dysglycemic. Probably 5 to 7% were in the diabetes mellitus range, and the remainder being in the prediabetes range. Now, this was not a diagnosis. This was essentially an identification of risk, and then the patients were to be referred on to a medical provider. We did a small pilot of about 100 patients to look to see how responsive the patients would be to that referral, and we found that 70% of them, with intervention on our part, actually reported back at 6 months having seen a medical provider. You also heard Cassandra mention another body of literature that's really fairly controversial, and that's that for people who have medical and dental services, dental care insurance, those that have chronic disease and access dental services have lower health costs and improved health outcomes compared to those with disease, chronic disease, who do not access dental services. Now, the data is from large data sets, for the most part from private insurance companies. There are potential for confounders that we have to be aware of. So you really can't say it's cause and effect, but it may be true, and unrelated. But that analysis is ongoing. We have a study now, and I think the study's progressed far enough for me to comment about this, that looks at the Medicaid population, that same phenomenon, but in the Medicaid population in New York State. And this is with the New York State Department of Health. The advantage to looking, or the reason to look at this in New York State, is that New York State has perhaps the best dental benefit of any Medicaid program in the U.S. And we are actually seeing the same thing for patients with diabetes mellitus, cardiovascular disease, cognitive impairment, and respiratory disease. And in fact, the magnitude of difference in terms of the healthcare dollars that are saved or that are not spent, as well as health outcomes, is actually greater than what we're seeing in the patients who have private insurance. Now, obviously, this is in a population that does not have Medicare as well, so it's only the 40 to 65-year-old individuals. So I think this is the other side of the equation is an important side. I think it would be remiss if we did not perhaps give greater concern and greater attention to that side of the equation. Thanks.
Thank you.